Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What is new with gout? Find out more right now. My guest this evening is Dr. Adey Berhanu, the director of the Gout Center at Arthritis and Rheumatism Associates right here in Montgomery County. Adey, welcome to Housecall.
Thank you for having me, Dr. Doman.
My pleasure, and please call me Dave. Okay. So tell our viewers briefly about your professional background.
All right, so I started my medical training in Chicago at the University of Illinois in Loyola, and I did my rheumatologic fellowship at the New York University. And then I came here to DC, was briefly a professor at GW before coming to private practice at Arthritis and Rheumatism Associates, where I am now.
Wonderful, wonderful. So briefly tell our viewers what exactly is gout?
So gout is a disorder of high levels of uric acid, which can accumulate and lead to crystal formation that can have consequences like gouty arthritis. It can also cause other accumulation issues in the kidney, like kidney stones, etc. But it is technically classified as a type of crystalline arthritis that we as rheumatologists treat.
And how common is this problem?
Gout is quite common. It affects about 15 million people in the US, which is about 5% of the population. It's quite common in men. We see it about 3 times more often in men than you do in women. Tends to occur in men after the age of 40, and in women typically in the postmenopausal state.
And you mentioned earlier uric acid. Is that the culprit here in terms of what's causing the gouty symptoms?
That's exactly right. That is the genesis of gout. And we do believe that the overaccumulation of gout can lead to, again, crystal formation that can then deposit in joints, leading to gouty arthritis.
Which joints tend to develop uric acid deposition, which lead to symptoms?
You can see gout attacks in any joint that's been described, even in rare sites like the spine. However, the most common sites are in the lower extremities. So we see this in the big toe most often. 90% of patients who have gout attacks will have had one episode in their big toe, followed by other sites like the midfoot, ankle, and knee.
Now, why is it that the big toe compared to the other toes is most likely a target?
It's a combination of factors. Part of it is temperature. So the further you are away from your core, the temperature cools, making the precipitation of crystals more possible. So that's why the lower extremities are more often affected. And then the big toe gets the most amount of trauma in our foot. So this also makes it more prone to developing gout symptoms and accumulation of uric acid.
How interesting. Now, patients that are prone to gout, do they therefore have elevated uric acid levels in their blood?
Absolutely. We can find that they have significantly higher levels of uric acid compared to the average patient. And this is part of what helps us identify them as gout patients.
And why is it that uric acid levels fluctuate?
There's a variety of factors that go into uric acid metabolism. Part of it is because we intake uric acid in our diet, so that can be one of the factors that affect whether our uric acid increases at times. And then other factors that can affect our uric acid is our metabolism. So we can find that we naturally break down uric acid, and it is our kidneys' responsibility to excrete it, and to some degree our guts as well. So any factor that can affect this process in the kidney can also affect the levels of uric acid in our bloodstream. So for example, Patients who take medications like diuretics, this can affect your uric acid metabolism. Genetic factors are most important here, actually, and these are actually the underlying factor that affect gout. Other things that can affect our metabolism include things like our weight. So other metabolic factors like weight gain or weight loss can also change the level of the uric acid.
You mentioned genetic risk factors in gout, so therefore can gout run in families?
Absolutely. We find that genetic factors are very important here. And we do find that patients will often report a family history of gout. There are genome-wide association studies that are now starting to identify a variety of different genes and genetic polymorphisms that suggest that there are transport mechanisms in the kidney that are altered, and these tend to obviously affect people in a genetic fashion. And you'll see that patients will often mention that their uncle or their father, their grandparents have gout. So we're looking to understand that more, but this is certainly something that has a hereditary factor.
How interesting. I understand there is a common myth related to the general public's understanding of gout. Can you clarify that for the viewers?
I think there's two great myths in gout. The first is that gout is just an episodic disorder that occasionally affects the joints. And this is a big paradigm shift now in our understanding of gout. Gout really is a consequence of chronic buildup of uric acid over time, over years and years. And so this begins early on, again, due to genetic factors that to some degree impair the kidney's ability to effectively excrete uric acid. So the uric acid builds up gradually over time. And eventually, when the concentration exceeds a certain threshold, patients now become more prone to developing attacks themselves. And so this is not something where a patient just gets a single episode and it goes away. The patient has a really high uric acid burden and will become vulnerable for subsequent attacks. So we really have to think of this as a problem that will be very likely to recur. In fact, after a patient has their first gout attack, 70% will have their second attack within that same year. Another big myth in gout treatment is that gout is a diet-related disease. And just like we mentioned, it is in fact heavily dependent on the body's inability to effectively get rid of uric acid. So while diet can be somewhat helpful and can somewhat contribute to the buildup of uric acid, ultimately diet alone is not sufficient in causing gout and also in treating gout.
Ironically, when gout was first described centuries ago, it was viewed as an illness of the well-to-do because they were eating rich foods, which could trigger gouty attacks. But certainly we're much more sophisticated now than back then. Let's talk diet, since it can contribute, even though it's not the sole cause. What are some so-called rich foods that can trigger gouty attacks?
Yes, so we call these high purine foods. Purines are ultimately broken down into uric acid. So foods that are rich in purines would be alcohol, specifically beer, seafood, especially shellfish, and then oily fish like sardines, anchovies, and then red meats. And highest on that list are organ meats like liver. And then newest to the list is high fructose corn syrup, which nowadays is found ubiquitously in a lot of the things we eat and drink.
Of course. So if those are the common offenders, what kind of foods do you recommend to patients?
We now know that there are some foods that are protective in gout. These include dairy, soy, coffee, and there have been small studies that suggest tart cherry juice can also be somewhat protective and have uric acid lowering effects.
How interesting. So what causes an acute gouty flare?
When a patient has high levels of uric acid, they will reach a concentration that now prevents the uric acid from remaining dissolved in the bloodstream and allows it to precipitate into a solid state. So it actually comes into a crystal state into the bloodstream. And this happens from a variety of triggers that can be dehydration, trauma, medications, changes in weight, a heavy purine load from the diet. And when this occurs, this crystallization happens, and that can often happen in and around joints. And this crystallization of uric acid near or in the joint leads to a dramatic response, immune response, that leads to significant inflammation at the joint, causing significant swelling, redness, pain, and the attack itself.
What are some of the different areas in the body that are attacked by these uric acid crystals?
So you can get uric acid in any joint, but you can also see it in surrounding bursa, tendons, and ligaments. But interestingly, uric acid, because it floats through the bloodstream over time with patients who've had long-standing disease, can start to deposit in a variety of tissues. So interestingly, on autopsies, they found uric acid in a variety of tissues, including the retina, the coronary arteries, the prostate, etc. Now, you don't have gout attacks in those places, but it goes to show that the uric acid is floating around systemically in the bloodstream. So classically, we see these attacks primarily in the joint.
We have 2 minutes before our break. You mentioned several times the effects on the kidney. So what happens when you get uric acid crystal deposition in the kidneys?
When uric acid builds up in the kidney, it can lead to the development of uric acid kidney stones. So this is different than the typical calcium kidney stones that we see. And this can cause painful kidney stones. It can also cause significant burden on the kidney's processing or filtering ability. And we do know that patients with high levels of uric acid are more prone for development of chronic kidney disease or progression of kidney disease.
Wonderful. Well, we're going to pause briefly for a public service announcement. When we return, more with Dr. Adey Berhanu, and we are discussing updating gout. We'll be right back. We're back. My guest this evening is Dr. Adey Berhanu, and we are discussing updating gout. Adey, let's go on to discuss how physicians such as yourself diagnose gout.
So gout is diagnosed ideally by going straight to the source. So if a patient were to come in with a swollen knee, us as providers would like to drain the fluid from the knee. We would take that fluid and look under a microscope, which would allow us to see the uric acid crystals. That is the most definitive way to diagnose gout. That isn't always feasible or logistically possible, so we do use other ways to diagnose gout. This can include lab work. We can check for high inflammation tests in the blood work. Obviously, we can check for the uric acid level in the blood work. And we can also use a variety of imaging techniques, X-ray being one of the most common. On X-ray, we can sometimes see signs of uric acid deposition around the joint of interest. And unfortunately, we can at times see signs of bone damage related to previous gout attacks at those sites. Newest to these modalities are things like musculoskeletal ultrasound, which we can now use directly at the bedside. And there's also a very new tool called dual energy CT, DECT we call it for short. This is a very specialized CT scan that can differentiate between different substrates and tissues, and it allows us to isolate uric acid, and we can actually see the location of uric acid and measure its volume in a given patient. So this not only allows us to confirm the presence of uric acid crystal at a joint site or within the body, but we can also measure its burden and also see how it responds as we begin to treat the uric acid or treat the gout.
Can you describe for our viewers some of the classic X-ray findings of gout?
Ideally, we don't want any gout damage, so it would be a normal X-ray, but what we can see on X-ray are two things. We can see cloudiness or haziness around the joint site. This suggests the crystal deposition, or what we call tophi, that can accumulate around the joint. So it'll be like a haziness that we can see. And the second is a bone erosion. This is where the inflammation over time actually erodes at the underlying bone cortex. And it often can look like a rat took a little bite out of an apple. And so this is our signs that we're looking for in X-rays for bone damage of gouty arthritis or tophaceous disease.
So let's go on to discuss then some of the treatment options you have. We've already discussed dietary advice you provide your patients. Let's go on then to discuss some of the therapies that are available.
When treating gout, it's very important to separate the treatment into, are we treating acute gout versus are we treating chronic gout? When we first meet patients, it's often at the time of an acute gout episode. So in those instances, we're trying to control the inflammation, the body's inflammatory response to the crystal. So our therapies are anti-inflammatories. There are three major categories that of anti-inflammatories that we use to treat gout. The first is a medication called colchicine. The second are medications that we call non-steroidal anti-inflammatory drugs. These are medications in the ibuprofen class, though there are many that we use that are prescription strength. And then the third category are steroids. Steroids can be given one of three ways. They can be given as an injection directly into the joint. They can be given intramuscularly, or they can be given as oral systemic steroids. The goal of these treatments are to reduce the inflammation, and with that, you can decrease the patient's discomfort and expedite the resolution of the gout attack. Now, when a patient has the treatment of their acute gout flare, I remind them that this is treating you in just this moment, but then there are also patients that you need to consider for chronic gout management. Chronic gout management's goal is to lower the uric acid. We're really trying to get to the crux of the problem here, which is to bring the uric acid level back down into a normal range so that they can mimic a non-gout patient's levels and thus not have the consequences of high levels of uric acid. The patients we consider to treat chronically should have one of 5 scenarios. We treat patients who have frequent flares. We consider a patient having more than 2 flare-ups per year as someone who is a candidate for long-term treatment. A patient who has any sign of bone damage on X-ray or signs of gouty arthritis. A patient who has tophi, these larger nodular collections of uric acid that can be seen externally or on imaging. A patient who has chronic kidney disease, or a patient who has ever had a uric acid kidney stone. One or more of these factors would be an indication to treat someone chronically for gout. Now, our most commonly used drug classes here are going to be medications like allopurinol or Uloric. These medications shunt the pathway and prevent uric acid formation. And these are very safe, effective, and have been around for quite some time. And this is usually our mainstay of treating patients. We have some older agents that have fallen out of favor due to less desirable side effects. We also have a new medication on the market that is an intravenous option that we use for patients with more advanced gout or for patients who have really significant tophi. This medication is called pegloticase. It's an infusion that the patient has to receive in the doctor's office. It's given, and the way the medication works is that it actually is an enzyme that can dissolve uric acid. So it has very impressive results. It can take someone's uric acid number down to 0. And we give this to patients for a number of months until we clear the system of the significant uric acid load. And then often we'll put them back on a drug like allopurinol to maintain their uric acid levels in the normal range. Once the uric acid levels are in the normal range, we can expect the patients not to have any issues like gout flare-ups or the associated risks related to kidney or otherwise.
I understand there's some home remedies and over-the-counter treatments available that may provide some benefit. Can you provide some explanation?
So important adjuncts patients can do at home are do things like ice and hydration. So these are very important for patients in an acute gout flare. And again, there is some very modest data suggesting that tart cherry juice could potentially be helpful, though again, we do recommend seeking your doctor for prescribed anti-inflammatory care.
Now, to further challenge us as physicians, particularly rheumatologists, sometimes patients may present with what looks to be a gouty attack, and it turns out it is not. It's something called pseudogout. So would you please explain to our viewers how you distinguish between one diagnosis and the other, and how you treat pseudogout?
This is an excellent question. The ultimate answer is that the molecule at hand is different. While gout is a disorder of uric acid, pseudogout is a disorder of what we call calcium pyrophosphate. So the best way to distinguish between the two is, again, to take a sample from the joint fluid, and when you look on the microscope, you are able to distinguish the two crystals from one another. So this is the best way to do that. If that's not feasible or possible, there are a lot of other clinical clues that can help us decipher between gout and pseudogout. The duration of flares in pseudogout can be more protracted, and pseudogout tends to happen in patients in the 7th, 8th, and 9th decade, whereas gout tends to start earlier in patients as early as their 40s.
So what are some of the biggest updates or new developments in gout care that our viewers should know about?
I just want to again emphasize we've had a real paradigm shift moving away from the emphasis on diet. So while again, avoiding purine-rich foods can be helpful, this is not sufficient by itself for gout management. At most, adhering to a very strict low purine diet can only lower your uric acid level at most by 1 milligram per deciliter, which is not very much. Whereas medications, by contrast, can lower uric acid significantly. Like I said, in the instance of allopurinol, can bring you, down 10 points if needed, and in pegloticase, something even more impressive. The second would be that uric acid levels that are high are not only associated with gout, but there is a very significant interplay with a lot of cardiovascular diseases and metabolic diseases. So we're now starting to see a very strong association of high levels of uric acid or gout with diseases, cardiovascular disease, chronic kidney disease, diabetes, obesity, fatty liver disease, and to some degree, even cognitive changes. So this is much more than just a disorder of the toe. This is something that can affect the system at large. And it is important to treat it for that reason, because it does have such an interplay with these other cardiometabolic factors.
That's a great line to conclude our interview. Thank you for a very informative show tonight. If our viewers have any questions, how can they reach you?
Sure. If anyone wants to reach us, you can contact our office, which is Arthritis and Rheumatism Associates, and you can reach our gout hotline, which is 240-908-GOUT. Thank you.
Thank you so much.
Thanks for having me.
My thanks to Dr. Berhanu for an excellent interview. My thanks to the team at the studio for making this show happen. And my thanks to you, the viewer, for joining us this evening. Next show will be a very interesting one. And by the way, it will be my last one because I am retiring. I'll be interviewing three colleagues, Dr. Stephen Rockauer, Dr. Michael Baum, and Dr. Stephen Hellman. And the four of us will be reflecting on 40 plus years providing healthcare in Montgomery County for our different specialties. It's going to be a very touching and final show. See you then next time for another edition of Housecall. Good evening.